All right, welcome back to respiratory number 5. We're looking at emphysema, which is an abnormal permanent enlargement and destruction of the alveolar walls. Now, remember, the alveoli is where all the action is happening, where oxygen and CO2 are being exchanged. Because the destruction, and it is permanent, of the lung tissue is happening at this level, the air is getting trapped in the lungs, the CO2 trapping and causing it to be um, causing the lungs to hold on to the waste. And remember that with emphysema, we have the elasticity, it's gone. So the carbon dioxide gets trapped in there, causing the hyper hyper reflection of the chest there, and the patients aren't able to expel that excess gas that's trapped in there. Over time, this can lead to pulmonary hypertension. It also can lead to right-sided heart failure, cor pulmonale, so which we all know from our history with AMP 1 and 2 that can lead to left-sided heart failure. So we're looking at, a lung disorder that can have a negative impact not only on the lungs but also the heart and the rest of the body. So when we have a patient who has been short of breath with doing the minimal of exercises like just walking or using the stairs, and they present to their physician's office complaining of these side effects of shortness of breath from just doing a little bit of walking, then what the physician will do is inquire further and ask them questions like, do they have a feeling of tightness in their chest? Um, do you have a productive cough when this happens? So are you able to cough up mucus when this happens? Do you have wheezing when this occurs? Um, the physician will go on to ask the patient if they smoke. It is the number one cause of COPD. Smoking is, with like 85% of the cases is due to smoking. So, but there's of course 15% that are caused by other issues. There is also a genetic deficiency. So there's an alpha 1 antitrypsin deficiency. Not many cases of emphysema is caused by this, but it is a genetic predisposition to getting emphysema. So again, we need to be aware of it. So the two primary causes of COPD again are cigarette smoking, which is about 85% of the cases, and then the alpha 1 antitrypsin deficiency. But then again, it could be anything from pollution to the job you worked. If you worked in the coal mines where you inhaled the dust and all of the um, contamination. If you build homes and were exposed to fumes from painting, from the building, from the installation of the padding that goes in the walls. Sometimes people are inhaling those. So there's a lot of things that can lead to the destruction of the alveoli. Um, that can cause emphysema to occur later in life, right? So these patients may not have smoked for years and years, or they may not have worked in the field that's causing um, this lung disease to occur, but it does have a permanent affect, and it is seen later in life. Permanent effect, and is seen later in life. Um, and we'll do a chest X-ray, take a full history of the patient, as well as look at their ABGs to see how well they're able to maintain oxygenation. And their treatment is going to be for life, right? Because once they get this condition, it's permanent, right? And it is long term for the rest of their life. And we'll do chest physiotherapy, help with ventilation. So that includes giving them bronchodilators, corticosteroids to help with the inflammation and exacerbations of the condition. Um, so they're going to be given albuterol and or Atrovent. That's the bronchodilators. Then, of course, corticosteroids such as Pulmicort. And then when they have an exacerbation of their condition, then we'll put them on an antibiotic that will help fight off the current infection that is causing the exacerbation. So if they have a bacterial infection, that is, we'll put them on an antibiotic. We're going to push for low flow O2. Remember, we don't want to encourage them to go above 5 liters on the oxygen because this can knock out their drive to breathe. So we're going to encourage them to stay 4 liters or below. So that can help them. And they need to be educated as to why this happens. The CO2 will build up in their system and will cause them to cause the brain not to remember to breathe, literally. So while they're starving for oxygen and it's on their mind all the time, if they turn up the CO2 above 5 liters, this will cause them to retain more CO2, which will in fact cause them to breathe differently, which will trap more and more CO2 and it will go up, and it's just a vicious cycle. So again, we don't want to knock out their drive to breathe. So we're going to encourage 4 liters or below. So looking at the mnemonics in front of you, COPD has patients are definitely easily fatigued. They do get frequent respiratory infections, right? They use their accessory muscles to breathe. They have cor pulmonale, of course, that's later in like the end stages of the disease itself. They are thin in appearance. Remember, it takes energy and to eat, right? And so we want to make sure that we're encouraging them to eat more fat, more protein, more calories, because they're going to get tired after about 3 or 4 bites and stop eating. We are going to encourage pursed lip breathing. This will help expel that CO2. They have a prolonged expiratory time. They are short of breath. They have a barrel chest. They have a chronic cough, and it is digital clubbing due to the lack of oxygenation. Emphysema specific is they are carbon dioxide retentions. They don't have cyanosis. They will not have a productive cough. It will be what we call an ineffective cough, like a dry cough. They speak in very short, jerky sentences because it's exhausting to speak. They get very anxious. They can't get enough oxygenation in their mind. They're using their accessory muscles to breathe. And we are going to keep a real close eye on them because we know the heart's going to be impacted by this disease process as well, right? So you and I breathe simply to release carbon dioxide rather than the need for oxygen. Our brains do it naturally. We don't have to think about it, right? Emphysema patients are not the same. They retain carbon dioxide, and again, they're starving for oxygen. It's on their minds all the time. So because they are CO2 retainers and starving for oxygen, that is their drive to breathe, right? If we turn up the O2 above 5 liters, then they're going to be retaining more CO2, which is going to knock out their drive to breathe. So we cannot, we got to encourage them to do 4 liters or less. Now, does that mean if they get sick and end up in the hospital, we won't go above 5 liters? Absolutely not. If they end up with pneumonia and we have to go above 5 liters while they're in the hospital, we'll do that while they're in the hospital. We just look to go back down to what they were on prior to this incident, and this is exacerbation. So that's what we're going to encourage them to do. Now, looking at chronic bronchitis, this is patients who have been, who've got exposed to chronic bronchitis and it has had it twice or more in less, like 2 really extended periods of chronic bronchitis, then they'll be diagnosed with actual COPD, chronic bronchitis. Again, smoking is the #1 cause. And in this case, mucus is getting trapped in the airways, causing inflammation to occur. And causes the narrowing of the bronchial tubes. It is also diagnosed on a chest x-ray. And if the patient's already having heart-related problems like cor pulmonale, then that can be detected if they do an echo of the heart. We're going to see an increase in the red blood cells and H&H as the body compensates to produce more oxygen for the body. The patient's going to be cyanotic, so they're going to be dusky color. They are going to have a productive cough with the mass sputum, lots of sputum. They're going to be hypoxic, acidotic, respiratory acidosis. They're going to be edematous. Of course, they're going to have an increased respiration rate. They're going to be short of breath, especially during exertion. Digital clubbing is very common. Their heart's going to be bigger. Remember, the heart's a muscle and it's working extra double time, so it's definitely going to be enlarged. They're going to be using their accessory muscles to breathe. We want to push fluids with these patients because they have those copious secretions, so we want to thin them out. So we're definitely going to push the patient to drink water. Adequate hydration will help them be able to expel those secretions if they drink water. Put them on bronchodilators, corticosteroids, mucolytics, and antibiotics for their exacerbations. And then finally, asthma. Asthma is episodic, so it happens where you have exacerbations and the patient will have times where they're completely fine. When they have an episode, though, of an asthma attack, this is when they'll have narrowing of the airways. It'll start with the patient wheezing. They'll be tachypnic, tachycardic. They'll have chest tightness. They may have a productive cough. You will literally see their nasals flaring, and they'll be very anxious. That's because they aren't able to breathe, right? So they're very anxious. Anything can cause an asthmatic to trigger an asthma attack. Extrinsic factors may include what's blooming in the air. It may be someone's perfume, or it could be an intrinsic factor, an underlying infection that they don't even know they have, right? Like a respiratory infection. It could also be stress, like nursing school, or it could be physical factors too. So we want to look at whether or not they have a family history of asthma, and then make sure that they're aware that they're going to be retaining CO2. They're going to have a prolonged expiratory. They're going to have increase in mucus, shortness of breath. They're going to have an expiratory wheeze. They're going to be tachycardic, restlessness, tachypnic. You might be able to see retractions when they're having an asthma attack. Usually we see people get asthma early in their years, like age 12. There's a higher occurrence in males, but it can happen to anybody, and it can happen later in life. You can have asthma when you're younger and outgrow it, or you cannot have it when you're young but get it when you're elderly. It is an emergency, though, if it's status asthmaticus. That means it's a life-threatening situation. And if you have an asthma attack, if a patient has an asthma attack and the medications, the bronchodilators, aren't working to treat them, then they should seek immediate medical help. It is a medical emergency for them. So again, we're going to treat with a bronchodilator like albuterol, and then once you get through the asthma attack, then we're going to put them on a steroid, corticosteroid, to help keep down those asthma attacks. So that's called the maintenance steroid therapy. That's the Flovent, and then of course they'll have their Atrovent for a maintenance bronchodilator, and then of course their albuterol for a rescue inhaler if they need it. Also steroids, we could give them steroids as well. Okay, this is it, and then we'll do one more. Thank you.